Hi YouTube, I'm Jack, a junior doctor working in London, and I finished my core surgical training. Today's video is about how to answer management questions at core surgical training interview. The management section involves a presentation as well as a management scenario, and today's video will focus on the management scenario side. I'll be talking about what a management scenario can involve, as well as running through my structure for answering management scenarios. At the end, I'll put it all together in an example answer to a scenario that I made up. Timestamps are up above. Please note I won't be revealing any interview questions during this video. All the examples are made up by myself. So let's go. Management scenarios assess how well you deal with non-clinical situations that can happen at work. First of all, I'd highly recommend getting the ISC medical book about medical interviews, as that has a good range of example questions in it. But for example, you could be asked about things like an unprofessional or difficult colleague, or dealing with significant incidents or never events. The management scenario will take up about 5 minutes or so of your 10 minutes management section. Next, we'll talk about how to answer these questions. So the structure I use for answering management scenarios goes as follows. Firstly, a general statement of the issues presented in the vignette. Next is SPIES, an acronym that you may have heard of. It stands for Seek Information, Patient Safety, Initiative, Escalate and Support. And finally, looking at the wider clinical picture and clinical governance. We'll discuss how to answer these questions in the context of an example that I've made up. You are the surgical SHO on call for the day. As you come to the end of your long shift at evening handover at 8 PM, 10 minutes have passed and the night SHO has not arrived. The registrar is non-resident on call and has already left the hospital at 5 PM. What do you do? So the first step is the general statement to show that you understand the question and the issues that are presented. In this case, you're waiting for handover and you're currently the only resident doctor in hospital for your specialty. Handover is an important patient safety event, and the concern is that your colleague has not yet turned up, so you're also a bit worried about their well-being as well, and you need to make sure they haven't had an accident. Next, you move on to SPIES. So seek information is the first step. Essentially, from the vignette, you don't have enough information to know what's going on. And to clarify this, you would open the rota and look for who is on call for the night shift, and then you would phone them directly. The follow-up question is as follows. You phone the night SHO, who says he is taking sick leave for burnout and had already informed the on-call consultant and rota coordinator that very morning. So now you have a situation where they may or may not be a night SHO turning up, or they may be a locum. At this point, you go on to the next part of SPIES, which is P for patient safety. And for this, you would say what your patient safety concerns are. Namely, there may not be a night colleague to cover emergencies, and also your rest might be affected, which means that if you're on call the next day, you're going to be more tired and more error prone. That brings us to the next step, which is initiative. Initiative essentially means doing what you can in your own power to resolve an issue. In this case, all you could say is that you cannot go home until adequate cover is found, and hopefully this won't take too long. The next step is escalate. This is a really important step and involves contacting your registrar on call in the first instance, and then the consultant on call as well, as they are overseeing the whole surgical take. Here you would like to clarify whether, firstly, they were aware that the night SHO was off sick, and also whether a locum was arranged. If not, then they would need to consider asking someone to cover a locum last minute, or even the registrar needing to come in to hold the bleep so that you're able to get some rest. Other people you can escalate to are the nurse in charge of the surgical ward. This can be helpful because the nurse in charge can avoid you being asked about too many ward issues while you're trying to sort out nighttime cover. In the escalation step, it's also worth discussing the chain of escalation. Essentially, this means if the first person you inform isn't able to help or is obstructive or unhelpful, then you would simply go up the chain, usually to their direct senior. For example, in a clinical situation, it would be your registrar, then it would be the consultant. After the consultant, it might be the clinical lead for your specialty, and then on to the divisional lead, if you have a divisional lead. And above that, you get to the medical director and the CEO of the trust. Similarly, for the chain of escalation, if it's an educational issue, for example, you're not meeting your training needs, you would first escalate to your educational supervisor, then if not that, escalate to your local postgraduate medical education lead, and then you would escalate to a regional training program director, or eventually the dean of the surgical school or of the foundation school. Essentially escalate locally before you then escalate regionally or nationally. Also note that filling in an incident report is part of the escalation stage, but we're going to discuss that a bit later. The final part of SPIES is support, and that means supporting all individuals involved, including any patients involved, yourself, and any colleagues. In this scenario, your colleague has taken sick leave because of burnout. It would be important to support them by advising that they speak to their educational supervisor and their GP if they haven't done that already. Also, if in this scenario you had to stay late, you need to think about supporting yourself. For that, you could arrange that with the consultant on call to allow you perhaps to come in later the following day. In this scenario, no patients were directly involved. However, if the scenario involved patient harm, then you'd need to offer an apology to the patient as per the duty of candour, and if relevant, of course, offer them the details for PALS, the Patient Advice and Liaison Service. Now, SPIES is adequate for a basic answer. However, for a really good answer, you have to look at the bigger picture. For example, in this scenario, the night SHO hasn't turned up, and that's the immediate issue. Once that's resolved, you ask yourself the question, was this a one-off, or has this been a repeating event? Has this been happening with this particular colleague only? Has the burnout been affecting the whole of the SHO cohort? The other question is, why was no cover booked? Was there a communication issue? Are people getting burnt out because of staffing issues? Moving on from these questions that you would have, you'd need to take some concrete steps to trying to make some kind of improvement. Assuming these events have had incident reports, you could collect these reports together and show them to the clinical lead or the audit lead, and this could form the basis of a quality improvement project. After that, you can talk about quality improvement and also mention that you'd present this at a clinical governance meeting. So let's put it all together. In this situation, my night colleague has not arrived for handover, and my concern is firstly for their well-being, as well as acknowledging that if I stay late, that will impact on my rest as well. My first step is to establish why the night SHO has not been able to turn up. I will check my rota and directly call the night SHO to make sure they're okay, and that may be enough to resolve the situation. So now it seems there's either going to be a locum night SHO or possibly no night SHO turning up. This becomes a patient safety issue. Somebody needs to be covering the night shift, and if I were to stay later, then that would impact on my rest and my performance. As I am the only resident doctor covering the specialty, I'll need to stay on site holding the bleep until we can make arrangements for appropriate night cover. I would like to escalate to my immediate registrar and then the consultant, who needs to be aware of any staffing issues on the on-call, and we'll try to work out an arrangement to ensure adequate cover, which may involve a last-minute locum or the registrar holding the bleep to enable me to get rest. It would also be worth me escalating this to the nurse in charge for the surgical ward so they know about the staffing issue, and if I have no success, to escalate also to the bed manager. An incident report should also be filled in, as it is a patient safety issue. After the event has been resolved, I would need to make sure that the original night SHO is okay and they're having support because they're clearly going through some burnouts. For that, I'd advise that they contact their educational supervisor and their GP. Also for myself, if I've had to stay later, I would mention this to the registrar and consultant and see whether I could perhaps come in a bit later the following day so that I have enough rest. And also for the registrar, if they've ended up having to do the night shift, then they would also need to have enough time to rest afterwards as well. And that may involve cancelling clinical commitments the following day. Once the immediate issue is resolved, there are a few other questions that arise. Firstly, was this a once-off event, or has this repeatedly happened? Also, has this always involved only one SHO in particular, or has this involved the whole cohort? Could this be evidence of a staffing shortage or a rota shortage? In addition, it's worth asking why no nighttime cover was organised. That may have been a communication or administrative issue. In order to take this forward, I would ensure that I've been filling out exception reports for these events and also incident reports. This data can be collected and presented in the form of a quality improvement project, which I would register, and then I would take this to initially my clinical supervisor and then also to the next clinical governance meeting. Another route of escalation would be through the Guardian of Safe Working, through the Junior Doctors Forum as well. Hopefully these will be sufficient to enable any changes to be made, and if not, then I would need to feed this back through the National Training Survey run by the GMC and reflect upon this in my portfolio. I hope that shows you an example of how an answer could be put together for this kind of station. If you haven't already, watch my video on answering clinical scenario questions and in general how to prepare for your core surgical training interview. I'll answer any questions in the comments. Like and subscribe if you want to see more, and I'll see you next time.